So, hello, all friends from IMCAS Academy. I want to thank you, first of all, for this kindly invitation. And for me, it's very important too, because I have, I combine this lecture with my friend from Nice, Philippe Castemont. And it's always a pleasure, to combine with a real surgeon and an anatomist. Because sometimes we find anatomists, but they are not surgeons. So this is a nice combination. So thank you. So this is we're going to talk about the tear trough, and what you are going to see is these are my disclosures. Of course, I have to mention it. And then all the videos you are going to see during the presentations, you can go to the marketplace of the IMCAS Academy. And then you can find, these 3D didactics, anatomy, surgery videos. All right. So don't spare your time, taking videos or with your iPhone, because you have all the videos at the marketplace. So those who know me since maybe 2008 know that I always follow these principles, that the why, where, when, what, and how. So today we're going to talk about the where, talking about the tear trough, and then talking about where. I don't know if you remember what we published in 2015. We published what we called the defining. These viaducts, and the one who's really focused on the tear trough was type 1. Nowadays, with my colleagues, Glenn Jelks, Oren Tepper, Eva Gisantes, and two more, we are making like a memorandum of all techniques together. And this is on press. I hope to be published, as soon as they allow us, to publish, as you know. So sometimes when, I give a talk about, tear trough, people say, why you talk about the cheek fat pads? I know that the cheek fat pads in regards to the mid cheek, but as you remember, Rory Campesa, in 2008, described these fantastic, fat compartments that you have to find out when you make the ink. If you don't make ink, you don't find them. But the most important thing, I think, is how they move these fat pads. And that's what, with my colleague, Glenn Jelks, and myself, in 2014, we describe the movement of the fat pads. And I think it's very important, the movement. The movement is what we call the gliding effect. This effect of movement of the cheek, I think it's important because what regards, the face moves in this direction, all right? Not in this direction. So this has been published too. So I think things that has been published that has some significant scientific approach. So we have all these fat pads, above the mass. Everybody knows the infraorbital, nasolabial, and middle cheek compartment. And then, of course, we have those who are at the surface mass, at the deep, close to the bone. And the one who's more important, for us, is this one, is the deep mid fat pad. Why is so important for the tear trough? Let's see. And then I know that Philippe, maybe he's going to say, why you talk about facial spaces is so difficult. But it depends from the backgrounds of the doctor. My backgrounds are, I'm a surgeon. And as a surgeon, when I do, for example, a facelift, I'm going to find out, the premassetary space, or a space like the preceptor space where you don't have, bleeding, where the nerves are outside. And these spaces are quite interesting, and they are not new. They came out in 1895, and this was a Juvara works. But it's true that Mendelssohn put all this. He did what we call an update on the about the spaces. So today we're going to talk about the premaxillary space. And what is this premaxillary space? The premaxillary space is a space that is located between the nasolabial fat pad superficial and the elevator labia superioris. This space, of course, is not a cave. is a space. We made these drawings to make this more clear, but it's not really a space like you see in this drawing. But it's when you place the cannula, then the cannula, you know, flies over it. All right. So we have this premaxillary space. Then what we found out is this following thing. Look what happened at the deep mid-fat pad. This is the deep mid-fat pad that sometimes, you know, decreases with age, with sports, with some disease. And if you look carefully, the orbicularis orbital muscle, this one, it lies over the cheek. That's why when we talk about the tear trough, we cannot forget this deep mid-fat pad, because the orbicularis orbital muscle lies over, you know, the cheek. As everybody knows, we have the pretarsal orbicularis, we have the preseptal orbicularis, and then we have the orbicularis orbital muscle. And in the middle here, in between the preseptal and the orbital, we have the famous, you know, the tear trough ligament. So remember this: we have the orbicularis orbital that lies over the cheek. So that's why when we work over the cheek and we work over the deep mid-fat pad, we just give some projection to this deflated, you know, part of the orbicularis orbital. So that's why the first thing we have, at least what we suggest, is always to fix, you know, this attention about the deep mid-fat pad to see if there is or there is no you know, projection or support in this region. As I said, you know, we have this you know, this is a video from not from me, it's from Mendelssohn, and then you can find this ligament in between the orbital part and the preseptal part. This is the eyelid, this is the nose. So, and this is an osteocutaneous ligament. It's not just for them, some people is a fiber, but we can find out, but this will continue with what? This will continue with something called the orbital retainer ligaments. So when sorry, I have to go back, see that. When we see this is the orbit, this is the, I'm sorry, it's too fast. This is the you know, the ligament in between the preseptal and the orbital, and then this continues all along the orbit, you know, giving the famous orbital retainer ligaments of the face of the orbit. So we have orbital retainer ligaments that start, you know, from the tear trough. So what about what kind of product? Today is we are not going to talk about any product, but the most important thing, as I always said, a good product we need to obtain a good aesthetic result, free of complication and with good evolution in time and compliance. As everybody knows, there is no really a specific product, you know, for the tear trough. We combine different products. So it's not the time. Today is a scientific session, so this will be another type of session. So let's talk about the analysis, the most important thing. Deep mid-fat pad to give support, and tear trough blending, and then the skin. This is the analysis of the tear trough involved. When we do the tear trough, my suggestion is not just to feel this as a single unit. Sorry, single hole. This is a hollow. It's a unit. I made these drawings, you know, like this, saying that the tear trough is not just this, is all this. All right, so this belongs to the deep mid-fat pad, and this belongs to the tear trough itself. So let's see this short video.
Just a small drawing of what it is, the three, you know, the three heads of the orbicularis or ocular muscle. We have the pretarsal, we have the preseptal, and we have finally the orbital one. So when you do the analysis of the orbicularis orbital muscle, you see that it's not really close to the tarsus, to the eyelid, but it's close to what? To the cheek. You see, the orbicularis is almost, you know, at you know, 1/3 of the cheek. So what is very important from my point of view is not just from this entry point or this entry point, you know, to go with the cannula and then to feel, you know, what, you know, mira para arriba, you know, to feel this aspect, or even from this part, just to feel, you know, this aspect, because what you are doing, it's feeling a hole, feeling a groove. And if you just feel a groove like this, she's going to keep still her face very flat. All right. Plus, from my point of view, when you just feel, that's the way. It's something in. I'm against feeling. I like a word called blending, to unify the lid and the cheek. Why? Because sonríe. When the patient smiles, this goes in this direction, don't you? In this direction. It doesn't go, relaja. It doesn't go to this direction. So I want to treat her tear trough using, you know, her natural movement of her face. First of all. And second, now I'm going to turn her head laterally, fíjate un poquitín así. And the first thing I'm going to do, I'm going to give support to the tear trough. Look to that. If I give support to the tear trough, you see that? I'm expanding the part of the orbicularis called orbicularis orbital. So not really the tear trough, because the tear trough is here. So the first thing I want to do, I want to expand this area. All right, and this area cannot be expanded, you know, superficially, but need to be expanded, giving support through the deep mid-fat pad here. So when I give support to the deep mid-fat pad in this region, I will give support to the tear trough and to the nasolabial fold. All right.
So why I mentioned this, because if you look, you know, for the vectors of the orbicularis has this vector. It has the insertions, the medial aspect, and it has, this is the vectors of the orbicularis. So if we just follow the vectors of the orbicularis, and we have, for any bad luck, fibrosis of the product, because I'm talking about the hyaluronic acid, I'm not talking about fat, you know, because fat is another issue, is a graft. So I believe that if we do in this sense, we're going to diminish, you know, problems. And this is why we use these different, you know. So you can find this, you know, at the app. And when we do, you know, this 8-step lower, you know, eyelid checklist, there's the last one is the arcus marginalis. And what is this arcus marginalis? The arcus marginalis is what it's, you know, is the fusion of the orbital septum, you know, into the periosteum. So, and this is a very hard. So what we have a debate with, you know, with my colleague, Dr. Jelks, is that we have this can be ini or this can be outi. When I make outi, it's millimeters, all right? I have made this a little bit far from the infraorbital rim, but this is, you know, the idea. We have ini and then we have outi. So when we ask our patients, you know, forehand, you know, we're looking, you know, in front view, looking up gaze, and we see, you know, the arcus marginalis, in between the arcus marginalis and the orbital radial ligaments, there is a space. In standard views, because of course, if the patient has a lot of retroseptal fat pad, this is not the case, then he needs surgery. This patient is suitable to do a blending procedure. What does it mean? That the patient is this, that the arcus marginalis, the red one, is quite far from the orbital retainer ligaments. When we have another patient that is outy, that, you know, then we don't see any gap between the orbit, you know, we don't see this. So what happened is this patient is not suitable, you know, for you know, treatment of the tear trough, medial or tear trough, medial or lateral. So I think it is a very easy, analysis about, looking up gaze for the patient, ini or outie. So then you see that this is fused, all right? The arcus marginalis is fused with the orbitoroidal ligaments. So then there's no space to, to feel, we can work over the cheek, we can work, but not over, the tear trough. So treatment, I like to use, as everybody knows, I like to move to cannula. So in all my entry points, I always use a small local anesthesia. I just use, the tip of the 21 gauge needle, or even I use the easy guide, and then I do my screw motion, to find the place. And how we do that? I mean, in our academy in Mallorca, we teach, our doctors, closing their eyes, trying to find, the place, because it's a matter of sensitivity. I mean, the needle, the only place that respects is the bone, but it doesn't respect the other layers we know. But in fact, the cannula really, is able, when you know it, to find, these spaces, all right? So that's why when we teach, our doctors, we close their eyes to try to find, the layers on the, on the piece of cadaver, all right? So I think cannulas for us, I mean, of course I use needles, but if you want to be, really on the quiet place, I mean, cannula in our hands is quite, safer. So we have options. So this is the question I always ask, when I give a talk, to the ladies and even to men. When we make up to the eyelids, tear trough, what is the purpose? To color or to blend? And then is to blend the lid and the cheek. So why we don't use the same concept when we treat our, our tear trough? So let me do this comparative shadow analysis with a very special person.
Buenos días, Chema.
¿Qué tal, Carlos? ¿Cómo estás?
Muy bien. Mira, esta mañana me he levantado con ojeras y te quería preguntar cómo podríamos conseguir un maquillaje natural.
Para conseguir un maquillaje natural, lo más importante es difuminar el párpado inferior con el pómulo. Si lo difuminamos, conseguimos una unión perfecta.
¿Y cómo sería un maquillaje no natural?
Un maquillaje no natural simplemente sería rellenando el hueco de la ojera o la depresión.
So this is Chema Juncos. He's a makeup artist, as you could see. He's Antonio Banderas. He's famous. And then I asked him, how do you treat, the tear trough? And so he said, as you do. And so, from a makeup artist, I mean, from this, these important persons, I mean, why not to have this idea? So that's why the idea of to give support for the tear trough and then to blend, I think is the same thing that hundreds of women do at night in the morning when they do their own makeup. So the options are the following, all right? So these are the feeling depression. I remember I gave, I was chair at the IMCAS Academy with Timothy Martin, as everybody knows, an excellent plastic surgeon. And he also said, irregularities is likely when fat is injected perpendicular to the church trough hollow rather than parallel to it. So this is the standard. Even at the plastic surgery, they made, this with the cannula, and then I think that when you do this, you are still, improving. Why? Because if for any reason you have what we call a fibrosis that may happen, you have this famous sausage effect. And when you have a sausage effect, it's not really, noticeable when the patient, it's in a frozen image, but when the patient moves, when the patient smiles, like this one, when the patient smiles, then you can see this. So that's why I'm saying that how to treat the tree trough using this technique. So using our principle is just blending, the area from the cheek and tree trough itself. So the first thing is to give support. So we're going to give support to the deep mid fat pad, and then to expand the orbicularis orbital muscle. So this is very easy. You go down to the bone, it's clear down to the bone, there's nothing there. And then just because all the arteries are superficially, and even with the cannula, even if you are close to the bone to go to the infraorbital nerve, you can't, because there's, the space is really very, very, very narrow. So it's just given space, and you go down to the bone, the deep mid fat pad. This is below the levator labis superioris. Of course, a lot of this product is going to be over the levator labis superioris, but you have to go down to the bone, and then you are going to give support to what? To the orbicularis orbital muscle. So this is the way I do it, with the cannula, just here, and then I give support in this region, the concave aspect of the maxilla, down to the bone, and then you mold it. You need 0.2, 0.3, and then how much product you need, that it depends on the type of skin, the type of patient. All right. So it's the easiest procedure to do it. You can do it. I mean, of course, you can do it with a needle, because you're going down to the bone. I prefer to do it, with cannula. And then the tear trough. The tear trough, what I like to do is I like to blend, as I mentioned before, I like to blend the lid and the cheek. And how I do that, I blend the lid and the cheek, crossing, with unifying, crossing the ligament of the tear trough in some cases, and the orbital retainer ligaments. Is a pop-up. You're going to leave, the product at the preceptor space. There's no arteries at this in this region. The only thing you have to take care about to put your finger, because the cannula can go into the retroceptor space. In case the cannula goes into the retroceptor, fat space, don't leave any product. Just remove your cannula. You can be very unlucky, to be inside. But I think if you go with the needle, sometimes you can have, something worse. So I think this is very useful, because you unify the lid and the cheek. So you go with the cannula. You ask your patient to look up gaze, then you see, the distance between the arcus marginalis and the orbital retainer ligaments, where you have to leave, your product, and then you cross your orbital, your ligaments, and then you leave your drops, and then you unify. You don't need too much, just unifying, and you will see that it's very. You don't have to feel the whole along. You don't have to feel all along. Just unifying, the lid and the cheek, like women's do every morning when they do their own makeup. All right. So this is how we do that with the cannula. I ask my patient to look up gaze, and then I go with my cannula, and then the question, where are you? I'm below the muscle. Those who has been with Philippe or myself, in dissections, the orbicular is a very thin muscle. So if you go below the muscle, you won't. You're going to be close to the bone. You're going to cross the ligament, and you're going to be at the preceptor space. All right, and then, as I said, slowly, you start, feeling all the whole region. You see here, you don't have to do it in just 5 minutes. It takes the time. It takes the time. Please cross the ligaments, because if you don't cross the ligaments, you have this balcony effect. All right. So this is the result of the patient. I like to remove, lights, because lights sometimes makes, a confusion. And then you can see, the changes of the patient. I won't be, in my hands, if I just feel, this, for me, this will be, an unnatural look. So that's why, first of all, give support to the deep mid-fat pad, then expand the orbicularis orbital muscle, and then blend the lid and the cheek. Like this patient, you see that if you just feel this region, you are not going to obtain a natural result. Of course, you're going to feel the hollow, but what you really need is to, first of all, to give support and then blend the area. But don't try to make just one single shot, even with needles or even with cannula. First of all, do your analysis to your deep mid-fat pad, and you will see that your patient will be, look, this is a patient with an INI. You see, this is the arcus marginalis, and this is the orbicular ligaments. And then the patient, after the treatment, 15 days after the treatment, you can see how this changes, in a very natural way. And then I want to show you the same patient right now, 8 months later. 8 months later, you can see the patient. This was before, and this was later. You see that even 8 months later, if you place, the product on your right space, it lasts. All right, that's why I'm always saying that this is a very technical procedure. It's not just filling. You have to. It's a very technical, procedure. All right. So just for finish, the medial tear trough can be treated as a single element. Deep mid-fat pad and tear trough has been blended, and of course the lateral need to be blended. Deep mid-fat pad for support and tear trough for blending. And remember, the O is gone, is a true osteocutaneous ligament. So those who maybe you have heard that some doctors try with the cannula or with the needle, to try to remove it. So maybe they can do it. I think it's nonsense. And it's a true ligament. For us, for people like Philippe and myself, we are surgeons. When we do a facelift, we cut the ligament, and you need to cut it. With a cannula, it's quite difficult. And then you create really, edema that I think is nonsense. So it's a very technical procedure dependent. And remember, blending versus filling, and from hollow to an area. Remember the concept of an area, right? And remember, you can find out, this at the marketplace. And as you know, we are in Mallorca, so we have nice beaches like in Nice, like in Corse, and we have also academies. So you are welcome to come to Mallorca anytime, not for the beach, for my academy. So I think Philippe, is your turn.
Thank you, my friend. It was marvelous presentation, and the concepts are very, very, very intelligent.